It's a real pleasure to be here with you today, and thanks to the Functional Gut Clinic for the kind invitation. So I'm just going to give you a whistle-stop tour really of what irritable bowel syndrome is and some of the treatments that we're currently using to treat this problematic disorder. But first, a history lesson. So irritable bowel syndrome has been around for a long time, and certainly in the 1950s in Oxford, they began to start adding a name to this disorder. And the first name that they put to it was what's known as nervous colitis. And as the decades have proceeded on to the present day, this definition and the term has changed slightly from what was called mucus colitis to spastic colon to the term we have at the moment called irritable bowel syndrome. And whilst the term has changed, I think the patients have largely remained the same, but currently we make this diagnosis based on the Rome criteria, and this is now currently in its fourth iteration. But essentially this is the absolute criteria that we're currently using. So patients must have weekly abdominal pain and then 2 or more of the following criteria. So some relationship to defecation, there's a change in frequency or form of the stool, and these criteria need to be fulfilled for 3 months before the diagnosis is made. That would suggest chronicity of symptoms or long-term symptoms. And I think whilst this definition is very useful for research to include patients into clinical trials of new drugs, I think this is a much more pragmatic definition of IBS in my mind. So in my mind, it's an ABC disorder consisting of first and foremost tummy pain, abdominal pain, bloating, and some change in bowel habit one way or the other. And indeed, this can change over time. But contemporaneously, we subdivide irritable bowel syndrome into really 3 major subtypes. So the first one is IBS with constipation. Again, that's pretty self-evident, as is with diarrhea. There's also a subtype where patients often get some diarrhea, then constipation, sort of mix and match between the two. But certainly these 2 disorders are generally speaking the most problematic and what I see in my outpatient clinic. So how common is IBS? Well, I think it depends on the definition that one uses, and the variance is very variable across the world. So the latest data from the UK, Canada and the US suggests somewhere in the order of between 5 to 6% of the population using that Rome 4 criteria. So broadly speaking, 1 in 20 people will have IBS. But certainly in China, almost a quarter of the population meet that criteria. And this has a huge burden on healthcare resources, and the latest estimates suggest that across the 8 leading healthcare economies worldwide, approximately $4.2 billion are spent on this disorder every year. But how does it affect patients in terms of their quality of life? Well, I think significantly. So this is a scale called the SF-36. This is a questionnaire where people rate different aspects of their quality of life, both their physical and emotional well-being. And the green line, as you can see here, is healthy people. And you compare this to the maroon line, which is people with reflux disease, indigestion and heartburn, and the grey line is those with diabetes. And as we can see from the next slide, that in fact IBS patients almost across any particular aspect of quality of life that you wish to measure have a reduced scores based on that scale. So it has a huge negative impact on people's quality of life, the things that they want to do, and their daily lives and relationships. So I mentioned that pain is the central defining feature of IBS, and we know that pain is very variable, both between individuals but also within a single individual on a certain day. And we also know that one man's pain is another man's pleasure, and indeed we know that pain can also occur in the absence of any injury that you can objectively demonstrate. So why is pain important? Well, there's a concept known as visceral painhypersensitivity. So this is means essentially that the digestive tract is much more sensitive to pain than one would expect. And this is really the leading idea of why IBS patients get pain currently. And this can occur both in the tummy, but also in the brain. And the tummy actually has a significant nervous system supply, what we term the enteric nervous system. And functionally, it's as complex as the brain. Indeed, there are as many nerve cells in the gut as there are in the brain of a cat. There are more nerve cells in the gut than there are in your spinal cord. So it's a very nerve-rich environment. And so what we term the enteric nervous system, we often refer to as the little brain in the gut, and that communicates with the big brain at the top, and also the big brain at the top communicates back down to the little brain in the tummy. And this cycle or circuit of communication is what we refer to as the brain-gut axis. And any problem at any level of that circuit of communication can lead to changes in movements of the bowel, but also perception of how the bowel is, and that can often be manifest as pain. So how is this concept proven? Well, as gastroenterologists, we like to stick tubes and cameras into people, and this was a group of patients with IBS and some healthy controls. And essentially what these investigators did was put a balloon in these participants' tail ends and began to inflate the balloon, and then asked the participants of this study then to report pain when they felt it. And these were the results from the study. So as you can see here, the normal participants didn't report any pain till about 75 mils of balloon inflation. And even going up to 180 mils, and that's now quite a big balloon in the tail end, only approximately 20% of people reported, i.e. normal people reported pain. But compare this to IBS patients, when you're getting up to those high levels of distension, over 50% of them reported pain. So this really demonstrates the concept of visceral pain hypersensitivity. So the digestive tract is much more sensitive to painful distension in this study. When I see a patient with IBS, I often ask myself, well, what's the patient's agenda when they come to see me? And I think first and foremost, if you've had some change in your bowel habit, you're getting abdominal pain, patients are generally worried whether they've got a cancer or not. And actually, I think allaying those fears are very, very important. Other factors: symptoms are getting worse. Am I crazy? They think it's all in my head. They're often seeing many, many doctors by the time they come to see me in clinic. Tried lots of medications. I'm sure you'll all be aware, if you go into a local pharmacy, there's probably a whole shelf full of different medications that are there to treat IBS. Patients have often tried many of those and they haven't worked. No one understands me. You often thought of as a group of patients, but actually each patient is an individual. And then finally, these symptoms are stressing me out. And going back to that idea of the little brain and the big brain communicating with one another, in fact, stress can make the symptoms worse. Are the symptoms due to stress? In many cases, no, they're not. Are they aggravated by stress? Yes, absolutely. So that's the patient's agenda. Looking at it now from the other side of the desk, I think you've got to think about what the doctor's agenda is as well. What do I do? They've tried all these medications. What have I got to offer these patients? Well, thinking about that cancer risk, one of the key objectives is to rule out serious underlying disease, and I would entirely agree with that. Being a doctor is a pretty stressful job in itself. Often patients and doctors, particularly GPs, only have 10 minutes to see a patient and get all of this history and all of these different aspects. Sometimes you're not sure what the diagnosis is. Could there be a psychological component? And actually we're very good at separating out patients with heart problems, they go and see a cardiologist. Patients with chest problems, they go and see a respiratory doctor. But actually what we have to remember is that each patient is one person. And all of these different organ systems interact with one another. So trying to divide it up and say this is just a problem in the digestive tract, in my mind, is counterintuitive. And does the patient have a hidden agenda? What does the patient want from the doctor? So I think this is a cycle that many patients experience in terms of what they feel and feel dissatisfied with the medical care that they've had. So lots of chronic unexplained symptoms. So what do doctors generally do? They order more tests. So they get multiple tests. They all come back negative. Not surprisingly, therefore, if patients aren't given a diagnosis, that the outcomes to treatment are poor. And you know what? Patients get bored with doctors, so they go and consult someone else. And I think the key thing to managing the IBS patient is really to try and break this cycle. And this now is not rocket science. I think it's 3 good tenets of good medical practice. So giving the patients the time, I think 10 minutes is just too short. Empathising with the patients. You can't fully understand what a patient is going through, but I think a little bit of empathy certainly helps build that relationship, and more of that later. And actually saying to the patient, yeah, I believe your symptoms. Your symptoms are real. You wouldn't be here otherwise. So what treatments do we have to offer patients with IBS? And I think broadly speaking, they can be classified into dietary and lifestyle modifications, and Megan's going to talk a little bit more about the dietary interventions. I'm going to concentrate on the pharmacological treatments in the next 5 minutes or so, but also psychological treatments can be very helpful indeed. And actually there's a very good evidence base for psychological treatments in IBS. Broadly speaking, the drug treatments for IBS can be divided up into 3 categories. So those treatments that focus on changing pain in some way, those treatments that are either designed to speed up or slow down the bowel, and those that change the bugs in the gut, what we refer to as the microbiota. And I'll touch on each of these in turn. So in terms of pain modulators, the first broad class are those that we refer to as the antispasmodics. And you may be familiar with many of these. These are drugs like Buscopan, peppermint oil, peppermint tea, which are very useful in terms of reducing spasms in the bowel. The problem with these drugs is that they were really developed in an era where the regulation around new drugs and data for new drugs was quite poor, and many of the trials are only in very small number of patients. But actually in some patients who are perhaps at the less severe end of the spectrum, these drugs can be very helpful indeed. I think one of the key drugs in treating IBS is the group of drugs which we refer to as the antidepressants. I think one has to be very clear with the patient in front of you why you're using these drugs. And if you start saying to a patient, actually, I'm using this drug because it'll help treat your pain, they may or may not be depressed, and generally speaking, the drug that we often use is amitriptyline, and it's not a very good antidepressant in itself. But actually it's very good at treating that tummy pain, which is that central feature of IBS, and actually can reduce the pain and discomfort. It has some side effects as well, some of which can be useful. So it generally slows people down a little bit. So if a patient has diarrhea, it can be beneficial. But I think one of its great benefits is it makes patients feel sleepy, because patients often wake up at night in pain, and if your sleep pattern's disturbed, then that in itself will often make the symptoms worse. If we think of the standard laxatives, again, I think these can be useful if used with some rationale behind them. And broadly speaking, these can be split up into fibre, those that soften the stool and make it easier to pass, those that give the stool a push from behind, what we call stimulant laxatives, and those osmotic laxatives which draw water into the bowel to make the stools more runny. One of the newer kids on the block is a drug called linaclotide. This was developed specifically for the treatment of irritable bowel syndrome with constipation. The beauty about this drug is that it has 2 mechanisms of which patients get benefit. So in essence, it causes a watery diarrhea, but it also affects the nerves within the little brain to reduce the amount of firing that goes up to the brain. So they get a pain benefit as well. When we test new drugs, we essentially get a population of patients with the same disorder and then randomly assign them to either the new drug or a dummy pill, what we call placebo. And in this context of a clinical trial, both the patient and the doctor treating that patient in the clinical trial doesn't know whether the patient's on drug or placebo. And this is what we call double-blind, randomised controlled trial. And this is some data in approximately 1,000 patients from the US with linaclotide and irritable bowel syndrome with constipation. This was a 6-month study. So actually you can see here placebo in the black. Actually, patients had a response to this, so a reduction in pain scores over time. But hopefully I can convince you that in the purple line, linaclotide outperformed placebo every week across that trial. So this is actually quite a useful drug and something I use quite a lot in my clinical practice. You'll have heard of Imodium. This is a drug called loperamide. This in essence reduces diarrhea by slowing down the movements in the gut and actually can be very effective. It often works very quickly, but I think often needs to be taken on a regular basis to exert its full effect. You may have heard quite a lot on the internet and in the media about this drug called rifaximin. This is a relatively new antibiotic. The beauty about this antibiotic for the gastroenterologist is that it's not really absorbed from the gut. So it's not a good treatment for, let's say, if you had a chest infection or something like that, because it doesn't significantly get into the bloodstream. And again, this was another double-blind, randomised controlled trial of 1,260 patients with IBS. And again, they were treated with either rifaximin or placebo for 2 weeks, and then they were followed for an additional 10 weeks. And the main outcome from this study was relief in IBS symptoms. And as you can see here, those that were treated with rifaximin had a very good response to treatment in comparison to placebo. But in fact, I think what these two studies show that placebo in itself is not a bad treatment in IBS. Probiotics, again, I don't expect you to be able to read this, but in essence, probiotics reduce the risk of problematic symptoms by 20% across when you amalgamate all the studies together. Certainly probiotics have a beneficial effect on the global overall symptoms of IBS, pain, bloating and flatulence scores. What I generally advise my patients is to try a month's trial of probiotics. You're going to know whether there's a signal in terms of improving treatment by then. But if it doesn't work, and they don't work in all patients, then to stop at that point. So overall, in conclusion, just a few remarks, if I may. IBS is very prevalent, it's common. Why it occurs, we don't fully understand as yet, but actually abdominal pain is the central defining feature. I think how the doctor and the patient interact with one another is very important in establishing that therapeutic partnership to improve outcomes. Equally, basic, simple management, getting the basics right first is also key. And certainly we have some of these newer medications and some new devices that are beginning to come online now, which I think will be very beneficial for patients, but used in the right way. So thank you very much for listening to me. It's a great pleasure to be here.